Good afternoon, and thank you for joining us today. My name is Lauren Kennedy, and I am a member of the board of Family Medicine for America's Health, the organization behind a new campaign to demonstrate the value of true primary care. Health is primary. Our campaign is collecting and sharing stories of innovation that are driving the future of health in America, and you will hear just a sample of the incredible work being done around the country from our speakers today. Family Medicine for America's Health is a newly established coalition of the nation's 8 family medicine groups. As Director of Health Policy for the National Partnership for Women and Families, I serve as the consumer advocate on the board. Our group has come together with one mission, and that is to improve health in America. As everyone knows, our nation is facing a health crisis. We have the most expensive healthcare system in the world, and yet we rank among last among industrialized countries in patient health. The good news is we believe the country is at a tipping point. A number of major shifts, including the Affordable Care Act, the Medicare Access and CHIP Reauthorization Act, the establishment of patient-centered medical homes, and improvements in health information technology have changed the healthcare delivery landscape, and we believe these changes present an opportunity to truly transform and improve our nation's health. It's time to put health back in healthcare. We believe the solution to many of our healthcare problems can be found in primary care. We are so convinced that we have built a campaign to tell the story of primary care and the innovation that is improving care and outcome for patients while also improving the return on investment for our healthcare dollars. The evidence for primary care is strong, and it speaks for itself. We know that access to primary care can help us live longer, healthier lives. In areas of the country where there are more primary care providers, death rates for cancer, heart disease, and stroke are lower, and people are less likely to be hospitalized. An increase of just one primary care physician per 10,000 people can decrease costly and unnecessary care. Outpatient visits and inpatient admissions decline, and ER visits decline by more than 10%. Evidence also shows that primary care is associated with helping to identify and address health disparities. Finally, U.S. adults who have a primary care physician have a 33% lower health care costs. Medicare spending is lower for states with more primary care physicians, and those states have more effective, higher quality care. Health, quality, and cost. This is the triple aim we must achieve, and we believe primary care can best deliver it. The Health is Primary campaign is working to deliver on this promise for primary care. A big part of that effort is our work to showcase primary care solutions from communities across the country. We have already been to Washington State and North Carolina, and we are headed to Illinois later this month. Our goal is to use these stops to bring together local stakeholders, including employers, policymakers, and patients, to look at community-level interventions that are working to enhance and expand primary care and improve health. There are different approaches in different regions, but the goal is the same: better health at sustainable cost. We want to learn from these examples, some of which you will hear about today, and bring them to scale. This is an ambitious effort, and it won't happen overnight, and we can't do it alone. But a big part of this effort is getting leaders like the ones you will meet today to share their innovation and best practices and to help us bring this kind of care to scale across the country. So I'd like to introduce Janet Marchabroda, our moderator today. Thank you for being with us. Janet is a leader in transforming healthcare and an expert in the role that health information technology is in driving that transformation. She's the Director of Health Innovation Initiative and the Executive Director of the CEO Council on Health and Innovation at the Bipartisan Policy Center. She has spent much of her career bringing physicians and other providers together to share best practices and to take healthcare innovation to scale. Janet, thank you again for being here to share these compelling stories from across the country and to help make the case for primary care.
Thank you, Lauren, for that kind introduction. We've got a terrific discussion planned for you today. As Lauren mentioned, we're going to talk about the important role that primary care plays in driving better care, better health, and reduction in healthcare costs. And I know that's something that is of great interest to the folks up here on Capitol Hill. I'm going to introduce our panelists, starting on my left, and then we're going to dive into some of their experiences, what they're experiencing on the ground, the successes they've had, the challenges they've experienced, to help provide information about how to move this forward more effectively to expand primary care. So immediately on my left, we've got Dr. Carolyn Lopez, and she serves as the president of the Chicago Board of Health and has extensive medical management experience in both the public and private sectors. Her past positions are many. I'll just share a few of them. The medical director of the Chicago Park District and chief medical officer of Rush Prudential Health Plans, chair of the Department of Family and Community Medicine at John H. Stroger Hospital, the old Cook County Hospital in Chicago, and very active not only in academic medicine, but also in the American Academy of Family Physicians on the board. On her left, I'm pleased to introduce Dr. Thomas Warkup. He comes to us from North Carolina, where he serves as the medical director of the Carolina Advanced Health. And he's going to tell us what they're doing down there, very innovative things around improving care delivery. He's a board-certified family physician with 10 years of clinical and administrative experience as the medical director of an Indian Health Service Health Center, immediate past president of the South County Hospital medical staff, and former associate clinical professor of family medicine at the Brown University School of Medicine. And then on his left, we've got Dr. Carol Heyman. And Carol is a physician. Dr. Heyman is a physician at Iora Primary Care. And some of you might have read a little bit about that. They've been in the press, great stories recently. She's a clinical assistant in addition to her work with Iora. She's a clinical assistant professor of family medicine at the University of Washington. She hails from the Pacific Northwest. And also served as the director of the Geriatric Medicine Fellowship at Swedish Medical Center for quite a while, and really enjoys managing elderly patients. Again, I know a topic that a number of folks here would like to hear more about, and we're very much looking forward to that. So let's get into it. What I'd like to talk about first, and maybe start with Dr. Heyman. Lauren talked a lot about patient-centered care and the importance of the physician-patient partnership. And if you look, as you learn more about primary care, you're going to see that family medicine is really built on a commitment to treat patients on a comprehensive and continuing basis, not just when you're in the office, but on an ongoing basis with coordinated care. And building those trusting relationships with patients is really important. And you probably didn't know this, but 40% of what drives health is actually how we behave, our behavior, things that happen outside of the office. And so with that, Dr. Heyman, I wonder if you might tell us a little bit about what Iora Health is doing, the model, and maybe some of your experiences with seniors in Seattle.
Sure. Well, hi, thank you all for having me here today. It's nice to see so many shiny faces in the other Washington. I'm here today representing family medicine. I'm also a geriatrician. And I have been the medical director for about 6 months of a brand new clinic that we just opened in October 2014 in the Central District in Seattle. Any of you familiar with Seattle geography? It is a neighborhood near the center of town, historically very diverse, lower income population. And our clinic was built to serve Medicare patients, so mostly people over 65, though we also have under 65 disabled patients in our practice as well. This is a new clinic that Iora opened, actually 2 in Seattle and 2 in Phoenix, both of which opened just in the fall of 2014, new ventures serving senior patients. Iora is actually a Boston company that was founded about 5 years ago and has I think 12 clinics in 7 states serving different populations that included seniors, but ours are the first that are really targeted specifically at patients with Medicare. Iora was founded with the ambitious idea of transforming healthcare. So we really believe in a few principles that have allowed us to do that. And one of them, as Janet mentioned, is to really provide patient-centered care, to really put the patient at the center of their health care, and therefore to build all of our systems, the way we construct our teams, the way we use our technology, the way we build our clinics, our physical space, sort of around that principle. Patients are really our customers, and we come at them with a very sort of customer service type of approach. The other thing that's neat that I enjoy about working at Iora is that we're not paid on a fee-for-service model, so we're allowed to sort of structure our care in the way that we believe is best for our patients. And that includes building a very robust care team. So we believe that the relationship between the patient and the doctor is obviously important and sacred, but that more stronger than that even is a relationship between the patient and the whole care team. So I have a team that consists of nurses and social workers. So we integrate behavioral health into the care that our patients get. We also have, we call them health coaches. We have a number of people on the team who really help the patients. They really talk to the patients about where they are and help them achieve meaningful behavior change, help them solve the complexity that our patients encounter in the healthcare system. They're really patient advocates, and they work as part of the clinical team. So, there's a lot of things we know about what makes chronic care work. One of the things that's wrong with the healthcare system, it's really built to do acute care, and acute care is important, and we're good at it, great. But really what drives most of healthcare is chronic care for chronic conditions, and our systems aren't built well for that. But there is a literature around what works for it. Chronic care works when it's planned, so we're not just waiting for people to be in crisis, we're actually planning what we're doing for them. When it's based on evidence, when we're actually following the science, we know what it is and we use it. When we encourage patient self-advocacy and self-efficacy, and that really is probably the most important of all of these. We really encourage patients to have ownership of their chronic medical conditions, to feel like they're okay and they can manage this with the help of their care team. And lastly, chronic care really needs to exist in the context of a longitudinal healing relationship. And that's what we think we can provide. So we're building our clinics around these concepts of chronic care. We're only 6 months in. I can tell you that getting a new clinic off the ground from scratch is no small task, so I'm a little tired. But so far, we've had some great results, and I'm happy to talk more about that.
Thank you. So next topic, lots of momentum around payment models, delivery models that reward better outcomes, right, versus more volume, between some of the provisions in the Affordable Care Act, MACRA, or the recent SGR replacement and chip extension legislation also has language there, and lots of activity, not just, in addition at the federal government level, announcement of goals by the HHS secretary. So lots of momentum within government, but also a lot of activity on the private sector level around moving towards these new delivery and payment models. So these models, as you know, talk about coordinating care, having more personalized care, streamlining processes, and primary care plays a very important role in these processes as we move away from the old fee-for-service infrastructure towards new payment models that reward value. as opposed to volume. So Dr. Warkup, I wonder, you're doing a lot of very innovative things in North Carolina, given your joint venture between UNC Health and Blue Cross Blue Shield North Carolina. I wonder if you could share with folks here some of your experiences, the outcomes you achieved, maybe some of the challenges in moving this forward.
So thank you. I'm excited to talk about Carolina Advanced Health, and we're located right in Chapel Hill, North Carolina, for any of the Tar Heel fans here. So we are a progressive primary care PCMH level 3 office, also NCQA diabetes recognized, that is focused on maximizing the team-based care, much kind of where you're beginning from. And the idea is to maximize this team-based care for those individuals with chronic medical conditions, diabetes, hypertension, asthma, heart failure, and et cetera. But we're a partnership between Blue Cross Blue Shield in North Carolina and UNC Healthcare Systems. And in this partnership, we try to collaborate on data about how to best care for our mutual patients. We've been around for 3.5 years now, so it seems that we're kind of old now comparatively to you. And in 3.5 years, I think we've made significant strides in getting access for our patients, getting our patients engaged, and I'll share with you some of our quality outcomes towards the very, very end. But let me explain to you 2 payment models that may come into focus for you very soon. The first one is what we're doing currently. It's called a medical expense savings model. So we are a fee-for-service office that has a bonus structure that's completely built on quality outcomes. And what we're morphing into is something you probably hear more about is clinically integrated networks, where you take a variety of healthcare system entities, allow them to collaborate on the triple aim, which gives them a safe harbor from antitrust violations, and then really streamlines the efficiencies in healthcare that I think we all would have liked, but it's really been pretty siloed over the last 20 to 30 years. And maybe for the very first time, we're all rowing in the same direction. That's kind of my IHS background. We have a foot in each canoe, but we're at least rowing in the same direction at that point. The quality metrics we have are almost all HEDIS-based. Not every metric we track has a HEDIS benchmark, but right now we track 22 quality metrics on a monthly basis. We hold the office to be above the 90th percentile in each one of those metrics, and we've been able to be successful in 18 of those 22 to be greater than the 90th percentile. And as a result of that, we've been able to really impact our patients' outcome, make dramatic impacts on our patients' health, but you can't do it without IT structure. So probably the biggest innovation, I would say, beyond the team-based care, which I 100% agree with, is how do we use that team? We have our own PharmD, our own nutritionist, we have 2 behavioral therapists, our own psychiatrist, our own care manager, and actually we have an embedded Blue Cross Blue Shield employee in the office that helps us with benefit structure. It's an amazing paradigm shift for any provider where you can instant message that person and say, based on a person's benefit structure, what would this cost or what would that cost? And get rid of the shock and awe value of what happens in medicine, because for any economists, we break every rule in the book. Nobody knows what the cost of medicine is. There's moral hazard. People only pay their copay, so they don't really know what the total cost of a sleep study would be. They have a $20 copay. So these are all obstacles that we have to overcome in medicine for sure. But we went from a proprietary system like Iora has, and we moved to Epic over a year ago, and that birthing process isn't always that easy. And what we've done is that for the first time in Epic's history, and Epic's a pretty ubiquitous EHR system now, where we've been able to risk stratify. So I can see every one of my diabetic patients, asthma patients, hypertension, depression, et cetera, and based on a rules engine that sits over the EHR, stratify them as a red, yellow, or green. That allows us to be very proactive of where to put resources. So how do you optimize that team and say offline, pushing care away from the office, which I think we all know that more and more has to happen outside of the 4 walls of the office, and dispatch the PharmD and the care manager out to, not into their homes, but make contact through telehealth. We do 15% of all of our visits electronically now both by video and by email. And reach out to those people that need the care the most in a proactive way versus the old model of medicine, which is the last time you come in or the next time you come in is the next time you get your diabetes taken care of, and that could be 5 months, 10 months, 18 months. That doesn't cut it anymore. I think as we take on these clinically integrated networks, which is all about risk sharing, as I take on risk sharing or the network takes on risk, we must be able to reach out to those individuals that hit the healthcare system the most. And that's one way to do that for sure. with the team-based approach, with the overlying IT system, what we're going to be able to produce, what we have produced, and what you'll likely be able to produce as well, is that we have a 40% reduction in ER visits, we have an 18.7% reduction in hospitalizations, 53% reduction in convenience care visits, but the real gem in this is with 11% reduction in primary care visits. In our early 1 year, 2 years, we had a lot of extra primary care visits which eroded into the health savings that we were hoping for. But now that we're able to be more efficient at the point of contact and use the EHR system to drive these best practice advisories, so when you come in as a diabetic or a grandparent comes in as a diabetic and we need this done and this done and this done, you get the right care at the right time by the right people so you can have the right conversation. All the providers here have been privy to a conversation with a diabetic who says, I think my eating's great, I've been doing really well, doc, and then their A1C, which is an average blood sugar over 3 months, is sky high. So you had this very general conversation, everything was great, but now if I know that, because I have the test result within 6 minutes of when they come in the office, you have the right conversation about really detailed care plans. So we're very proud of what we've been able to do for 3.5 years. I think we're morphing into this clinically integrated network, which I think Advocate's probably the biggest leader in that, 4,500 docs under this one roof. We're hoping to get about 3,000 docs when we're fully mature, and I'm happy to take questions at the end.
Great, thank you. And these new models are really emerging across the country. It's something that we've spent a lot on at the Bipartisan Policy Center, looking at delivery system reform and transformation. But the other topic that we're spending a lot of time on is this intersection between primary care and prevention, primary care and population health. And I'm really delighted that Dr. Lopez is willing to share some of her insights on how one has health care and public health working together to improve health and health care for all of us. So would you mind sharing some thoughts there?
Thank you very much, and thank you for the opportunity to be here. I'm really delighted to have this privilege. Family medicine is at the juncture of public health and the population. And it becomes an imperative for us to recognize that at the outset. In 2011, the Department of Public Health in Chicago published a comprehensive health plan called Healthy Chicago. It truly was comprehensive, but among the many things it attempted to address was the issue of smoking cessation. So why did we as a board decide to tackle smoking cessation and tobacco use as an issue? We've heard a lot about chronic disease and how it's handled at the practice level, at the system level. The question is, how do you then handle it at the population health level? We held a series of town hall meetings and actually heard from our population, or from our folks, very diverse groups, that they wanted us to address issues because they were afraid that their kids were starting to pick up bad habits, and they wanted us to help them with that. And they included things like flavored tobaccos, including menthol, and this novel new thing called e-cigarettes. And so we went about the business of drafting policy, but policy in and of itself, without the push of many people in the community, and it took a lot of folks. It took practicing physicians who took time away from their practices to come and provide testimony, not only at the town halls, but also when push came to shove at the city council, and including a last-minute press conference. It also took a collaboration with all the interested stakeholders, the Respiratory Health Association of Illinois, the Chicago Asthma Consortium, a number of the other related, the Illinois Heart Association, that was the one I was missing, all the key folks, and we all came together and we were all working in behalf of this, and as a consequence, we were able to encourage and and successfully have our council pass ordinances that brought e-cigarettes under the Clean Indoor Air Act. So our e-cigarettes have been regulated since last year. We extended the distance from schools where tobacco products could be sold. So we went from 100 feet to 500 feet. And the upshot of this was that our smoking rates for adults are at an all-time low. We dropped it down from over 22% to 17%, a little over 17%, which is more in line with the national average. Our teen and youth smoking rates are down absolutely to an all-time low, from 13% to a little over 10%. And again, because we were successfully able to regulate e-cigarettes, we don't have the problem that is now seeming to be an issue where youth are picking up e-cigarettes and becoming addicted to tobacco products that way. And I am happy to entertain any questions you might have.
Thank you, Dr. Lopez. And we're going to open it up here for questions in a couple of minutes. But I have some questions for the group. You know, one thing that folks are talking a lot about are the notion of shortages in primary care, challenges of recruiting and retaining clinicians. And I know that satisfaction probably plays a key role in all of that. And as we look at ways to assure both a sufficient and a sustainable primary care workforce, I wonder if any of you have any thoughts, your experiences around how your models, the physician satisfaction, how you address that. Dr. Heyman?
Sure. So I think this is really important. In fact, in our clinic, we think that the triple aim should really be the quadruple aim, and the fourth leg needs to be physician and, frankly, team satisfaction, not just the doctor. The team members need to be satisfied with the work, because you can't just reach the triple aim by balancing it on the back of people who are overworked and burn out and quit. Actually, previous to opening this clinic, the last 10 years of my professional career, I was in a teaching position in a residency program. So I taught in a residency in Seattle in family medicine, and I trained new family doctors, and I also ran a geriatrics fellowship, so I trained young geriatricians. And one of the, my graduates would finish training and go out into practice, and often what I would hear back from them is, I feel like I learned how to do medicine the right way, but the way that I'm having to do it is often not the way that I know it really should be. Evidence-based, patient-centered, having a relationship with a patient over time, taking the time that it really takes to do the right thing for a patient. And the frustration that my graduates had, and I would hear that from them, made me really feel like the next phase of my career needed to be about, well, let's build a clinic and a system of clinics where people can be doctors the right way and have the right incentives to do the right care and create their longitudinal relationships. I really think, and so what we found so far, it's been very satisfying for me. Other people are very satisfied. The trainees, sort of medical students, undergraduates, residents, they're fascinated by it. We can't get enough. Every week somebody wants to come look at our clinic. Doctors in training are very excited, I would say, about some of these new ways of practicing medicine, because it's going to let them do sort of what they want to do in their heart, and it's one of those great alignments between the right thing is also the thing that they want to do.
I would echo that, and I think we both agree of trying to target medical students that have an aptitude for it, have a real desire to do primary care, but I have a real passion to try to make it the retention of our current physicians, and burnout is significant. This might be a staggering number. So it was published out last year. Nearly 400 physicians committed suicide a year, and because of the rate of burnout. And that comes from, and almost directly from, dissatisfaction. I think there is a disillusionment in medicine between what I think we thought it would be like and what it actually has turned into. So getting back to like a team-based approach, professional satisfaction, patient satisfaction, doing things in an evidence-based way, I think is going to go a long way to keeping our current doctors stable and keep them in the healthcare system, because I think we all benefit from experienced, trained, competent primary care doctors and not always kind of build it from below, but we need to keep the resources that we currently have. But burnout is a major issue, and this hopefully will address some of it.
You know, family docs are made of medical students who have a heart and really, really want to just help people. Our AAFP president shared a story of a resident that he was teaching and noticed one afternoon that he went into a patient's room and came out and he wasn't wearing any shoes anymore. And in asking the resident, how come you don't have any shoes, he found out that the resident just said very matter of fact, well, the patient I was just dealing with just had flip-flops. He really didn't have shoes. I asked him what size he wore. It happened to be my size, so I just gave him my shoes. And that's the kind of thing that can happen on a one-to-one basis. But boy, you go through your shoe budget real fast if you're trying to do that by yourself, you know. And this is where, again, that juncture with public health, where you can work on fixing the problem not just for the individual sitting in front of you, but for the larger group. And I think people having an awareness of that and being able to have that hook into that builds on the kinds of changes that have been discussed in the transformation.
So if we could switch gears a little bit, you know, we've a lot of momentum up here, as well as in the federal agencies and the private sector around moving away from payment based on volume to payment based on value. Could we talk a little bit about that? You know, how do we accelerate some of this movement? What are some of the challenges that clinicians, primary care physicians, clinicians are experiencing? You know, what needs to be done? Any thoughts from our panelists on that?
Yeah, I would say two things strike me right away: IT, cost parity, and regulation. So from the IT standpoint is, right now we can do telehealth. It's not a new concept. We've been doing it for a long time. But right now, under an old fee-for-service model, the old dying model that we just keep polishing, is that we are disincentivized to use the technology. So I'll give you an example. I could see an asthmatic in my office today and bill a 99214, which is a code, and say you get a round number, say $100 for argument's sake. I could see them in 48 hours to see how well they're doing by video. I can see their face, I can see what's going on, I can talk with them, and that would be approximately $35. But you can't get paid for it. So therefore, you're incentivizing me to bring you back in for another $100 visit, which I've even said to our Blue partners, I just don't understand that it's a complete discrepancy there. And they shrug their shoulders and they say, well, we're fearful of these new claims. So I think IT parity, so making that an office would get reimbursed on par with office-based visits where IT, and also doing electronic email communications. So email communications video adds value, no doubt about it, but it makes a lot of sense in a fee-for-value world, not in a fee-for-service world. And the second part is the regulations. The regulations that come, I think, from centralized areas is without an understanding of what happens on the ground. You know, you have meaningful use. You have offices that are struggling to become PCMH, then deal with meaningful use, then now meaningful use 3, and then all these other kind of accreditations which are necessary for momentum and maybe reimbursement, but doctors view it a lot of times as clicking the boxes, and I'm clicking the boxes rather than taking care of the patient in front of me. So there's got to be a hybrid where the IT structure is 100% necessary. There is no way for us to take all the best practices in medicine and remember it all and have it at our fingertips without an IT EHR system that brings it right to at the patient's visit. That's wonderful. But trying to understand the regulations about even some of these chronic care codes that are coming out, where is it, do I need to make a transition care plan for just the individual's most prominent chronic medical conditions, or is it all? And the amount of admin time is spent, even at University of North Carolina, saying, is it all or most? And going to the Federal Registry to try to figure out what the language is, because your consultant said one thing last week that you paid $4,000 for. So I think it's that regulation that is a little bit, needs to be streamlined for us.
Other thoughts from our panelists?
Yeah, we're also paid in a fee-for-value type of a system, which I think is critical for the work that we're doing. It allows us to target the care that the patient needs, not the care that I can get paid for. And that has included things like, just a telehealth story. I had a patient who was dying. He was 90. He lived in a nursing home. And he had had a recurrent, he had several events resulting in hospitalizations. He had conditions that could not be cured by the best that medical technology had to offer. And his family was struggling with the challenging issues around, did they want to keep putting him into the hospital even though they weren't really curing him? And those are important and hard conversations to have. But the patient's daughter, who was trying to make these decisions, lived in California. I'm in Seattle, and the patient's in a nursing home 10 miles south of me. Well, I managed to arrange transportation for this patient, which was another issue. I had to have somebody in my office arrange that for him so that he could come to the practice along with his wife, who met him there, and we put the daughter on a video chat on a screen in the room from California. And we had this important, hard family conversation around what the goals of care were for this family and how we were going to help in service to them to help them achieve their goals. And it was very, I'm also a hospice and palliative care physician. I've done a lot of this kind of work over time, and it's very important and meaningful. And I'd never done it on a video before, but you know what, it worked. And that daughter did not have to leave work, fly to Seattle, sit in the room with the patient, right? So that we could do this thing that we were able to do. And I'm happy to say that that gentleman died peacefully in his bed at the nursing home with his loved ones at his side, and his daughter's last visit with him was on the video in my office. So we really enabled this very meaningful thing to happen, and we were using some technology that we couldn't have, that we wouldn't have been able to do in a more usual system. I've also, another patient of mine who's landed in the hospital and probably tens of thousands of dollars in medical costs because her heart valve had failed, because she hadn't been able to get her blood thinners and take them. And this was before she came to my practice, actually, and she'd been getting care in a typical practice. I actually know her doctor. He's a good doctor. He's a good guy. He was trying. But, the patient's too disorganized. Her life was chaos. She couldn't get to clinic when she was supposed to, so she didn't have all her blood draws. So therefore, he was like, I can't give you this medicine. And it was just one of these things where she was a square peg and he had a round hole, and they did not fit. And so she could not get the care that she needed. And what happened was her heart valve failed, and our fantastic acute care medical system saved her life. But now here we are again, right? So now we've really got to figure out how to meet this patient where she is. And believe me, that's not, you should come to the office every 2 weeks and get your blood drawn. You should, because that's not going to work for her, right? So what we need is my social worker has to talk to her. Her health coach has to go to her house and see her. I got to get the home health nurse from the cardiology office to call my office every time she wants to make a medication change for that patient, right? We've got to coordinate complicated care in a meaningful way, none of which is reimbursed if you're not paying for value.
If I can expand on one point and think about telehealth in regards to everybody in this room, what do you make per hour? So what does it cost your health care per hour comparatively to somebody that is, not to be disparaging, but let's say who's the Walmart greeter? It's very different for your per hour to take time off from work, travel to where you are, wait in the waiting room, get the care that you get, and then get back to the office. If that evolution takes 3 hours, how much does that cost per hour for you to be out of the office? Comparatively to engaging you where you are, at your home, at your office, and it allows you to be more engaged and probably more accepting of kind of treatment plans because you're able to get at them in a way that it's not punitive or pejorative, and that's how that's viewed. And so engaging them in a way that makes perfect economic sense, but it certainly meets you where you are.
That's certainly something that they've been talking about on the Hill as recently as this morning when the Health Subcommittee voted on the 21st Century Cures legislation. Dr. Lopez, any thoughts on that point before we move?
I think everything that's just been described, I would add in only that so much of this and the effectiveness of it is based on that longitudinal arrangement, a relationship that's been established. And that's where there's really the payback for that opportunity to interface with patients in such a unique and novel way.
So just sort of reflecting back on what I heard, my next question is really about, well, what can policymakers do to drive this transformation, supporting primary care? And, we've heard a lot of examples. Dr. Heyman talked about supporting this coordinated care, complicated care more effectively, maybe through reimbursement changes. Dr. Workup talked about the health IT regulations, helping health IT become more usable and supportive of coordinated care. Of course, telehealth, we're not there yet. We're not close in terms of the policy supports that are needed. And then just general regulation, I don't know if I would call it burden reduction or just, tweaking with the regulation, and of course finding ways to connect public health, population health, prevention with primary care. Any other things, given where we are, things that policymakers could do to help drive primary care and transformation? Any thoughts?
What comes to my mind is beyond streamlining the regulations so that way well-intentioned organizations like the three that we have here can fulfill the spirit of what we're trying to do, not necessarily trying to check all the boxes to make sure that we're not in trouble. And the next one is, I think any conversation without some sort of tort reform wouldn't be fulfilled, because telehealth, we are scared to death to use telehealth for non-established patients. There's a conversation at the board levels at probably every state medical licensure. We could do it. It has meaningful, but we are afraid of it because most state societies have come out with regulations that said, let's be clear, if you're trying to treat somebody at a retail pharmacy, it's you we're going to hold responsible if that person has an untoward outcome. So that way we use it, and I think you probably use it as well, in your established patients only, because the new patients that haven't been to your office, which you may have to expand your mind about what is the traditional patient-doctor relationship. Medicine is so neat in the sense that we're so steeped in tradition as much as we're steeped in evidence, and sometimes the tradition gets out in our way a bit. But the issue is, if we could have some type of clarification or relief from that type of issue, I think you'd see greater uptake, besides the parity of cost.
Other thoughts on policy? I know we talked about it along the way.
Well, certainly the payment reforms are a critical part of this because that supports all the work that's being done at the levels that have been described. And that gets tied to what measures do you pick. And that has to be driven by the folks who are actually doing the work because we're the ones who know that if you set a particular target for this patient, it may work fine, but for another patient, they may come back and tell you they weren't taking the medication because they felt so bad, because it was getting them to diabetes to a point that was too low. So it really has to be in the hands of the clinicians who are the ones who understand that one size doesn't fit all. As much as we think that would be easy, it actually makes it much harder. And we have to really do targeted, thoughtful approaches to how we're setting our targets for these measures.
Okay. So what I'd like to do, questions from our audience, questions for our panel. Now that you've heard, yes, the gentleman in the back.
Yes, my name is Richard Hyde with the American Association of Kidney Patients. Thank you for taking the time to share this very, very good information. Looking at things from the patient perspective, how have they accepted the changes? Because we're talking about particularly when you're dealing with elderly patients, and I kind of say that tongue in cheek, but when you're dealing with elderly patients, because they may be a little bit resistant to change, and certainly with the change in payment models, changing from fees to, just the overall health, as they call it, value-based.
That's a great question.
That's an interesting concept, but just maybe speak to the practical application from a patient perspective, how they're dealing with it.
Great question.
Yeah, and I agree. I agree about sometimes older folks don't love a change. And, you know, and I've got a new clinic too, so we've got a brand, I mean, I've actually been practicing in the community for 15 years, so I'm slightly known as a person, but the clinic is new and the brand is new and nobody's ever heard of it. So those are all changes, and change is hard, not gonna lie. You know, and, but what I can tell you is that we actually take patient satisfaction very seriously, and patient satisfaction, another topic I have strong opinions about. You can go both ways on patient satisfaction. Some of the stuff that you see about patient satisfaction tells you that it can be a driver of some negative things. But I actually call that patient satisfaction on the cheap. I think you can cheaply make people satisfied by giving them drugs that they don't need and antibiotics that they don't warrant, and there's some things like that. And that's not, to me, that's not real bone-deep satisfaction. I actually trust my patients. Ultimately, they know what's right for them. And what we have found in our clinic, because we've built a care team that includes, for instance, health coaches as an integral part of the care team that come from the community that we are serving. So they really sometimes can relate to patients in a direct way that's sometimes, frankly, a lot more effective than me, the doctor, coming in and doing that. And as part of that, like, I have a health coach, and her name's Lisa, but her patients call her My Lisa. I've heard so many times, My Lisa. And, you know, it's, we built really beautiful clinics, not in a really beautiful part of town. Some of them are in strip malls, and people are like, wow, this is a beautiful clinic. And part of it makes them feel like, these people, they care about me. They're making this about me and my needs. And I actually think that then you don't have to sort of get into the whole thing of, I'm denying you health care. I'm going to give them any health care that they need. But a lot of people are getting health care that they don't need. And if I say to them, you know, honestly, I think for you, I can do some of the things that your other specialist doctors were doing. I can do some of that here. Almost all the time, they say, that's fantastic. If I don't have to go there and pay the bigger copay and spend, and remember, when I talk about, and that's going to lower costs, sure, but what's cost? Cost is suffering, right? That's that patient spending a day in the cardiologist's office that they didn't need to spend, or that's a hospitalization that they didn't need to have. And so if we can, you know, make a place for them where they feel like they're important and that their views are heard, and that I'm going to listen to them, and also that I'm competent, they're going to be satisfied. And we have, the only data we have so far, we haven't been open long enough to have real outcomes data, but we have patient satisfaction data using the Net Promoter Score, and it's very strong. It's through the roof. It's well above the industry standard.
It's an interesting time in medicine because we're battling two different things. One is, I think the patient satisfaction side, which is immensely important, has made us be better. You know, anybody who's in a traditional office, the schedule was built to protect me, not for you. There's no way you can call at 2 in the afternoon. You can't see the doctor. You're crazy to think you're going to get in today, right? Because it was there to protect my schedule. So it's made us be better with open access and better hours. But the struggle is the consumerization of medicine a little bit too. They're getting a lot of mixed messages. You've got retail pharmacies. You got a lot of this convenience care. They're getting care that isn't necessarily the best place to get it in the most evidence format, but it's convenient. And I think we're dealing with that kind of cherry picking of medicine and leaving very sick people now to the rest of us, which isn't a good balance. So I think the mixed message is that you can get any access at any time you want, at anywhere you want in a retail environment, let's say, but really we need to be better at maximizing that same access in a better quality patient-centered home.
You know, I think the critical part of this to remember is that this is all patient-centered, and patient-centered means not where I think the patient should be or where the insurance company thinks the patient should be, but where the patient actually is and what their context is, and not try to impose anything upon them, but instead engage them. And then I think even old fogies like me will adapt to the change, because it actually is something that I see is a value to me.
Other questions from the audience? I think we've got a woman here. We've got 3 questions. Yes, and then back.
Yeah, so the first thing that happens is our day starts with a team meeting. So we spend the first hour of our day not seeing patients, but actually focusing on the team thinking together strategically about who needs care. Now that's already somewhat radical, right? Instead of I'm open the door, who's going to roll in today? Number one, and it's not just who's on the schedule for today and what are we going to do for them, the sort of huddle that's become somewhat more traditional. No, ours is who are we worried about? We actually have a thing called a worry score. We run it on everybody. So the people with the high worry scores, we pull them up. Everybody who's been in the hospital, everybody who's been in the skilled nursing facility, anybody that somebody in the room is like, oh, you know what, that guy going through divorce, kind of worried. I think he's going to stop taking his heart medicines. Or my congestive heart failure patient who has to watch her sodium intake, she called me. She just went to Jazz Fest in New Orleans. I'm worried about her sodium intake. Can we get her in and look at her? Right? So we're talking about our population and who needs our help, and we sort of make a plan for the day. So that's cool. Then we have appointments, and we have a mix of same day, schedule. Our policy is if you call and you want to be seen today, I'll see you. We're going to figure out how to do that. So but we try not to therefore fill the schedule too full of the sort of routine stuff that we just are in the habit of doing, right? So, but we have some of that. I always have place for telephone visits, as Tom mentioned. I think that's really important too, because I can actually manage cardiovascular disease risk factors on the phone almost all the time. Like if I'm really managing your cholesterol medicine, I don't need to see you. You don't need to come driving in. So, so it's a mix, phone visits, office visits, and team time, sort of planning time. I actually block out a few hours here and there in my week specifically to work on the health of my population. So that's my time where I'm thinking about, let me strategize, how's my hypertension control? Let me look at my population with high blood pressure. Who's high? Okay, why are they high? Longitudinal healing relationship. I know why they're high. They're not just a number to me. Let's figure out what intervention is going to work for that specific individual. Well, this is part of starting a new clinic. I would say that is in development. Right now, I'm the boss, so I just, we're deciding, but that's part. Yes, it's an excellent question because this is the question, right? The question's like, how big a panel can a doctor really manage? Mm-hmm. We don't really have an answer to that yet, right? You probably are close to having an answer on that. How many visits really can you do in a day? What is it different if it's urgent versus chronic care? How much time do you put into your outreach? Yeah. Really good question.
So do we have time for the 2 questions? If we go to the gentleman in the back here, and then there was another gentleman here.
Hello, I'm Mike Abraham, the neurologist. I'm wondering, you mentioned the high cost of chronic care, and Dr. Lopez talked about it being patient-centered. What about those patients who rely on neurologists, rheumatologists, endocrinologists, OBGYNs for their primary care services? What are your thoughts about incorporating them, so not just family medicine, but all of the physicians that are providing comprehensive primary care for patients?
Well, you're in the medical neighborhood, okay? There's a medical home and there's a medical neighborhood, okay? And I would say that I love working with my neurologist, okay? The neurologist is a critical part of that medical neighborhood that we need. The comprehensive care you're providing is for the neurologic problems that the patient has, okay? I think in my case, if my patients have a problem with a cough, they're going to call me, and they're not necessarily going to call the neurologist. Okay? And that's not just true for that. I mean, for the OBGYN folks, same thing. We have to work very closely with them, okay? And we want to work very closely with them. We're colleagues. It's important that we recognize that when we talk about comprehensive care, we're really talking about who the patient's going to call when they have constipation, after the surgery, who they're going to call when they have whatever other problem that isn't necessarily in the same ballpark, as critical as the care is that's being provided by our subspecialty colleagues. It's just not necessarily in their ballpark. Likewise, boy, do I rely on my colleagues in the subspecialty field because I'm just a humble family physician. I do not have half of the answers. I just have a lot of questions.
Thank you.
Thank my neurologist talks to me all the time about how they do get the call about the consultation. And they may go to another physician to figure that out, but it's always coming back to the neurologist. They have
Great.
a child with epilepsy and severe seizures. Those parents are going constantly to the neurologist for every single condition. And women with their OBGYNs
Yeah.
constantly doing that.
You know, a
I think
significant,
we've got,
if I can answer something on that, a significant piece of that is being part of that medical neighborhood, which I 100% agree with, is getting you to feel comfortable graduating these people back. If there's a person that hasn't had a seizure in 2 years, you don't need to see them every 6 months. But there's kind of that legacy effect that happens, graduating people back so I can find you your next most important patient to be seen. And the reason that's important is we go into these value structures, I need access. I can't have, in neurology in Chapel Hill, it's a nightmare. And you would think in 2 major academic institutions of Duke and UNC, we'd have tremendous neurological access because they're being bogged down with things. You're seeing somebody post-stroke that you're putting on an ACE inhibitor, which then should have been done by their primary colleagues. And then you're following them up to get their creatinine done because you don't know if they have a PCP. So there's got to be more communication bidirectionally to get rid of some of the clutter in your access so I can get people in before they hit the ER or the urgent care or, more importantly, the hospital because they're staying once they hit there. So I think it's more of that neighborhood of that back and forth respect and communication.
great. You get the last question of the day.
Thank you. My name is Noah Sanderson. I'm a fourth-year osteopathic medical student. I actually have 2 brief questions. The first one is, there hasn't been any discussion yet of the role of non-physician providers in delivering primary care. I was wondering how they fit into your particular programs. And the other question I have is, every year we've seen a shortage of medical students pursuing primary care specialties, internal medicine, pediatrics, family medicine. And I was wondering what kinds of issues you think is causing that, as well as what kind of incentives we can do to promote more of our students going into primary care.
I think, I mean, as an osteopath, I think 2 things that come to my mind in that is I think everybody on this table probably doesn't look at these APPs as somebody else in the system. I think we just use them, they're colleagues of ours. So I have a PA, I have a PharmD who's an immensely helpful person in my office. So I think utilizing those people as team members is very important. It's not an inherent trait that doctors have in our generation. We're taught to be autonomous. Every decision has to flow through me. The answer is that those days are gone. I need to be able to have somebody doing that work for me. So it's very routine for me to see a diabetic, and then the PharmD sees them next, and then the PharmD is titrating them, sees them in 2 weeks, and then keeps going, and then allowing you to be more the captain of the ship. So I think for the APPs have a tremendous role in this system, And I think the medical school side, this is the first time in history that more clinicians would dissuade their children from going into medicine than any other time. And that's part of that disillusionment. You know, there's a book that was written, it was called The Disillusionment Doctor of a Doctor, and it talked about in that first 30 pages, it was captivating to say, here's what we thought. We go from the House of God book references that kind of build the generation all the way to kind of the newer paradigms. And I just think that in the 50s and the 60s, when physicians were making 5 times the median salaries, and if you want to really look at it, it's been pretty stagnant. Yeah. And then you have finances going beyond it. You have all these other promotions that go through it, or any other professions that go higher and above. So I think the younger people are kind of going in other directions, and medical school debt. Medical school debt is significant. I'm 14 years out, and I still pay my extra mortgage a month to my student loans. And I was in the National Health Service Corps. So it's a reality of having the combination of the debt, combination of the disillusionment, and but I can tell you right now, it's an extremely rewarding profession, and people should go into it because it's never dull.
There's 2 drivers, and they've been mentioned. It's the salary and it's the lifestyle. And I think with the reforms that we're making, that a lot of the lifestyle and satisfaction gets fixed.
Any other thoughts? Well, this has been a terrific panel. Please join me in thanking our wonderful panelists today. Thank you.